I'm Stephanie, and I'm a certified personal trainer.
Hi, I'm Kate, and I'm a registered dietitian nutritionist.
And this is a podcast dedicated to educating women on their journey to optimal health. There's so much that we can do to optimize our health, but we've talked to so many women who just simply don't know how.
These conversations are what inspired us to start Omnia Fit. The Omnia Fit podcast is all about interviewing certified professionals to educate women on improving our health. We'll talk about things like stress relief through exercise, what we need to know about our hormones, the truth behind fad diets, and more. So subscribe, follow along, and let us know if there are any topics you want to hear more about. Hello, everyone, and welcome back to Omnia Fit. I am joined here with a fellow RD, Julie Cunningham. Welcome, Julie.
Thank you, Kate. Happy to be here.
Julie is a registered dietitian as well, and she is a certified diabetes care and education specialist. She runs her own private practice, and she is also a newly published author. Very exciting. Her book is called 30 Days to Tame Type 2 Diabetes, and it is available both as an ebook and a paperback. So congrats to you.
Thank you.
And if you kind of just want to go into what your specialty is, why you're passionate about diabetes, and kind of what you do now as a dietitian.
Yeah. I've been a dietitian for over 20 years, and when I started, to tell you the truth, I became a dietitian because U.S. News and World Report said that careers in nutrition were going to explode. And I really didn't know what I wanted to be when I grew up, but I thought, okay, that sounds good. You know, I like medicine, but I don't like blood and guts. So I picked to be a dietitian, and that's how that got started. So when I first finished grad school, I took a job as a WIC director, and I did that for a couple years. And then I started working in a high-risk prenatal clinic, and there was a ton of gestational diabetes in there. And that was my favorite aspect of my job, but I didn't really do anything about that. And then I moved towns, and the only position that was available in my new town was as manager of a diabetes clinic. So I interviewed, and somehow I got the job, and part of the deal was that I had to become what was then a CDE within a year or two. So I did, and I loved it. I loved it more than any other aspect of nutrition that I had worked in. Really, I think because I get instant gratification from working with people with diabetes. You know, if you're working with somebody who has, cancer, it's a long-term process, and it feels kind of depressing. Or, weight management can take a really long time. But if I have a client with diabetes and their blood sugars are 400 today, and they stop drinking Coke or whatever it is that's running their blood sugar up, they could be in the 200s tomorrow. And I love that sense of instant gratification. I also had 3 out of 4 grandparents who had type 2 diabetes, and I watched them suffer at the end of their lives, and it doesn't have to be that way. So I think those two things put together are, those are the instant gratification and the ability to change the outcome of somebody's life. Those two things put together are really why I like working in diabetes.
Yeah, and can you actually go into a little bit more about what a certified diabetes educator, or CDE, as you mentioned, is, kind of what that process is, and the overlap between that and dietetics a little bit?
Yeah. We used to be called CDEs, Certified Diabetes Educators, and then maybe 3 or 4 years ago, they changed our official title to Certified Diabetes Care and Education Specialist. So there's 2 more letters in the acronym now. In order to become a CDCES, you have to have several years of experience working with clients with diabetes, a certain number of hours, and I've been one since 2005, so I really don't remember how many hours that is, but it's a fair number of hours. And you also have to pass a national examination, and then you have to continue to pass that national exam every 5 years, or get 75 hours worth of CEUs that are specific to diabetes. So as a dietitian, because I specialize in diabetes, I can really get all my CEUs in the diabetes area, and they count for both my RD and my CDCES. So that's typically how I work it.
Do you have to be a dietitian to be
You
at a
do not
CDE?
have to be a dietitian. You don't have to be a dietitian to be a CDCES, but you can be a dietitian. You can be a nurse. You can be a pharmacist. You could be a physician. I believe you might be able to be a physical therapist. So you have to have a formal education, some kind of formal healthcare background, and then get the CDCES on top of that. So I like being a CDCES because of that interdisciplinary action. You know, I get to be in the same group with nurses and PTs and pharmacists and people from a variety of different disciplines rather than just nutrition. And we all have our bit of specialty. But it does give you extra leeway as far as being able to interact with physicians. You know, if I just had an RD, I might not be able to say, gee, I really think this patient would do better on this other medication for diabetes than the one they're on right now. I did not have that confidence before I became a CDCES, but now, because I keep up with all that stuff, maybe I'll see a patient who's on an old-fashioned medication and their sugars are running low frequently and they really could do better with something else, then I feel, you know, confident and capable that I can send that recommendation over to the doc and that they will most of the time pay attention to that.
Yeah, and that's something that we talk a lot about on the podcast is the importance of credentialed health experts. And part of it is that reason is because so often when you're credentialed, you have to keep up with the most current scientific research. And that adds so much value to the clients that you see because you always have sort of that up-to-date knowledge versus the outdated old cliche knowledge about something that anyone else could sort of repeat. So as a diabetes expert, do you want to go into a little bit about the different types of diabetes? You mentioned working with gestational diabetes when you started. So sort of what's the difference between type 1, type 2, gestational, etc.?
Sure. So there's, I guess, basically 4 different kinds of diabetes. You have type 1. That is an autoimmune disease where the body attacks its own beta cells in the pancreas and destroys their ability to create insulin. So we used to call type 1 diabetes juvenile onset, and we don't really call it that anymore. But if you have type 1, you're typically very thin because you're losing weight because you're not able to use the carbohydrates that you're eating. And you might also be very thin because you are in a state of DKA. So type 1 is autoimmune, used to be called juvenile diabetes, and really only about 10% of people in the US who have any sort of diabetes have type 1. If you've got type 1, you're going to have to take insulin shots for the rest of your life. Although there is some research out about pancreatic cell transplantation, you know, that is very uncommon. And typically you would be using insulin multiple times a day or on an insulin pump if you have type 1. If you have type 2, that's what we think of as a lifestyle disease. It used to be called adult onset diabetes, but because we are seeing more and more children developing type 2, that label has been taken away. Type 2 is more of a lifestyle condition, so risk factors for type 2 are being overweight, being sedentary, having a first-degree family member who also had type 2, and if you're female and you've ever had gestational diabetes or delivered a baby that weighed more than 9 pounds, that puts you at risk. Certain ethnic groups, basically any ethnic group that is not Caucasian, is more likely to develop type 2 as well. And then we have something a lot of people have not heard of, and that is LADA, L-A-D-A, latent autoimmune diabetes of adulthood. So these are basically type 1s who are diagnosed after age 40. Typically, a type 1 will be diagnosed in childhood or into their early 20s, but people with LADA have that latent adult onset, but it's still type 1 and they still need insulin. And then the last one is gestational diabetes. You may already know that insulin production in pregnancy doubles and sometimes triples, and usually that happens around 24 to 28 weeks gestation, and that's why people who are pregnant get that nasty orange glucola drink. at around the beginning of the third trimester. So when a pregnant mom is unable to produce enough insulin to handle her needs and her baby's needs, the result is gestational diabetes. So most of the time it's fairly mild and it's diet controlled, but sometimes people do need insulin injections for gestational diabetes. And there are a couple of different oral medications that some physicians will try, and others will just stay away from that and they'll just use insulin.
So I'm actually curious, you mentioned how we're getting more juvenile age group diagnoses of type 2. What sort of triggers the diagnosis of type 2 diabetes in younger people? So how do they sort of realize that they have type 2 diabetes? Because I know with type 1, a lot of times it's the weight loss, a lot of drinking water, a lot of urination, and that's sort of what people look for with type 1. What are sort of the warning signs that type 2 might be prevalent in a younger person that isn't sort of that typical age group for what we think of with type 2?
Right. A person with type 2 can have those classic symptoms of diabetes: very thirsty, urinating a lot, dizzy, headachy, just really feeling bad. But most of the time, a person with type 2, whether they're a child or adult, they're not going to have those dramatic symptoms. They'll just feel a little tired, a little run down, a little bit lack of energy until things really get bad. But the biggest predictor in children is excessive weight gain. So if a physician sees that the child is overweight and also sees potentially something called acanthosis nigricans on the neck, that is it looks like a dirty neck. Some people will come in and they'll say, I just keep washing my child's neck and washing my child's neck. Of course, this happens in adults too. I keep scrubbing my neck and I can't get this dirt off. And it's almost a velvety textured coloration around the neck, and that is a symptom of insulin resistance. So if a physician sees that, they certainly would do a blood test. They would check fasting sugar or hemoglobin A1C. But they might also check just if a kid is complaining of lethargy and not feeling terrific, and coupled with weight gain.
And I know with type 2, a lot of times people get diagnosed first as pre-diabetic. Do you kind of want to go into the stages of that and what that means, and sort of at what point that can be reversible as well?
Yeah. There's, blood sugar exists on a continuum. It's not like we flip a switch and all of a sudden, boom, we have diabetes when you're type 2. That might happen in type 1. But with type 2, things sort of happen on a continuum. So we used to just use fasting blood sugars or random blood sugars to diagnose diabetes. Not that I diagnose, the physician does. But now, a few years ago, ADA decided that hemoglobin A1C could be used as a criteria for diagnosing. So a normal hemoglobin A1C, which really just means how much sugar is stuck to my red blood cells. A normal hemoglobin A1C is going to be 5.6 or less. A hemoglobin A1C between 5.7 and 6.4 is considered pre-diabetic, and a hemoglobin A1C of 6.5 or higher is enough to diagnose diabetes. So when you fall in that gray area, it's kind of like a yellow light, a traffic signal. It's a warning sign, and your body is saying, hey, I can't handle what's happening here. I don't have terrible overt symptoms, but I'm going down the wrong path, and we need to turn this bus around, right? So most people, by the time they're diagnosed with type 2, they've already lost 50% of their pancreatic function. But if we can catch them early, but 50% of people with prediabetes can reverse that by getting 150 minutes of cardiovascular exercise a week, and by losing 5 to 7% of their body weight. And that's not a lot. If you have a 200-pound person, that's 10 to 14 pounds. It's not terribly hard to get that off, and it's not terribly hard to either walk 22 minutes a day or 30 minutes 5 days a week. And half the time, that'll reverse prediabetes. Type 2, even if you've spilled all the way over onto type 2, it's sometimes reversible within the first 5 years or so. After about the 5th year mark, it becomes much more difficult to reverse either prediabetes or type 2 diabetes.
Yeah, and I know as well there can be sort of a genetic component. So what are some genetic underliers that people should note in their own family tree in terms of whether they should be aware that they're at a higher risk for diabetes?
Yeah. As I mentioned before, any ethnic group that is not Caucasian, that is an automatic risk factor. And then if you have a first degree relative who had type 2, a mother, a father, a brother, or a sister, your risk for type 2 diabetes goes up. So you need to be aware of those things. And if either of those applies to you, then it's even more important to get that daily exercise and keep your weight in control as best as you can.
And so when you're seeing clients with diabetes and as a dietitian, you're talking about food, what they should be eating, etc. What is sort of that biggest group of advice that you're giving people? And what are sort of the misconceptions? Because we hear a lot like, I dated someone for a long time who was type 1 and people would see him eat cake and say, oh, you can't eat cake, like you can't eat any sugar or carbs. So what's sort of a lot of that misconception that you first see people with, maybe even when they first get diagnosed, and sort of where you meet them at with making dietary changes?
Yeah. Well, a lot of people will come in and they'll say, I can't believe I did this to myself. I can't believe I let this happen to me. If you're type 1, you didn't do anything to yourself at all. It is not your fault. There's nothing you could have done differently. If you're type 2, yes, probably you could have exercised more and probably you could have managed your weight a little bit better. Possibly, although there are some type 2 people who are not overweight, so that's a whole thing in and of itself. But people feel a tremendous sense of guilt, especially when they have type 2. And that's not healthy. It doesn't help us to move forward when we stay stuck in that guilt. So I like to reframe that for them and say, listen, our society is not built to keep you healthy, right? Our grocery stores are full of processed junk food. We are built to use cars and not sidewalks. Everything that we do does not lead us toward a healthier path. So we have to make a really conscious decision to work hard. We're not set up to be healthy. It's just not easy to be healthy in our society. So I want to remove that guilt and I want to say, you are where you are right this minute. We can't go back. We can't go back 10 or 20 years and change the way that you behaved then. We can only start with where you are right now and change what you're doing from this day forward. So I really work hard to get people to let go of that sense of guilt and also to find, what is your motivation? Sometimes people come because the doctor said they should come and they're not ready to change their eating and they're not ready to change their exercise habits. And that's okay. I'm here when you are ready. But sometimes people have a little bit of a struggle finding their motivation. I don't really like to use weight loss as a motivation. You can change your eating habits and change your exercise habits. And some people will lose a lot of weight and other people's weight will stay the same. But my goal for my clients is your blood sugar where it needs to be? And are we preventing those long-term complications of diabetes? That's my goal. So typically I'll use a little bit of a motivational interviewing exercise with them where I ask them, on a scale of 1 to 10, how motivated are you to change your health right now? And they'll tell me their answer and we'll go through what's the payoff to staying the same? Because there is some value in staying the same. People are used to what they're used to. They like the food that they're eating. There's payoff to not changing. It's comfortable not to change. But then we'll talk about, okay, what would be your motivation to change? Maybe they want to have a baby. Maybe they want to spend time with their grandchildren. Maybe they're looking forward to retirement and they want to travel. So then we weigh the pros and cons of staying the same versus getting to that place where you're able to do the things that you want to do in spite of your diabetes. And most of the time, that's pretty helpful. And then I might get them, if they say they want to travel, I might get them to pull pull some pictures off the internet or cut pictures out of magazines of places they want to go and use those as motivation when times get hard. Maybe they even tape it to the steering wheel of the car if they have a struggle going through the fast food line all the time. And people tell me that's really helpful to have a concrete reminder of why they're doing what they're doing right in front of them at the time that's in question, at the time that they have to make an actual decision about what am I going to eat or what am I going to do.
Yeah, we've talked about that power of internal motivation a lot on here, and it really is the driver of change, as much as external factors and outside support and all that is important. The biggest thing is finding the reason why you want to make a change and why you want to change the way that you're living.
Yeah.
So in terms of management of diabetes, it definitely varies between type 1, who are insulin dependent, and type 2, who may or may not be insulin dependent. But do you want to run through sort of the tools that we use for managing diabetes?
Yeah. There's basically 3 ways that you can manage your diabetes. If you have type 1, I typically use carb counting. That's pretty easy. It's straightforward. We can figure out what is our insulin to carb ratio. Every time I eat 10 grams of carbs, I need 1/2 or 1 unit of insulin. That usually works for people with type 1, and that's the way that I tend to go with them. So carb counting is an option for both type 1 and type 2, and most of the time that's where my patients fall because the other 2 kinds of diets are more extreme. Secondarily, some people manage type 2 diabetes with a ketone diet, and that's fine if that's what they want to do. I understand that eating very low carb has its benefits for some people. It is not what I encourage people to do because number 1 killer of people with diabetes is heart disease. So I'm concerned that if a person wants to eat a very low carb diet, how much unhealthy fat are they eating and are they clogging up their heart?
Yeah, that's really
but that's a choice. Yeah, it's a choice, and it's a choice that a lot of people embrace. So there's that. And then to me, the gold standard for people with type 2 diabetes would be changing to a vegan diet. There's a lot of research out about how a vegan diet can help reverse type 2 diabetes. I don't know if you're aware of Neil Barnard. He's done a ton of research about that. So that's a good resource for people if they want to check into that. He's at Physicians Committee for Responsible Medicine. So anyway, the vegan diet is the gold standard if you ask me. However, I hardly ever have a client who is willing to embrace that. So I live and work in the suburban South, and people like their meat and potatoes, and that's okay. I'm not a vegan either. I don't eat a ton of meat, but I'm not a vegan, and I can understand that they like their meat and potatoes. So usually carb counting is the way that I tend to fall out.
Yeah, and then in terms of, let's say that people do have to start an insulin regimen, whether they're type 1 or type 2, what are some of the ways that we do that? So whether it's the shots or the pumps, what's sort of like the technology right now around the ways that we distribute the insulin?
Okay. Most of the time, if a person is type 1, that's a different ballgame. But speaking about type 2, most of the time a person with type 2 is going to progress through a series of different oral medications. And then there are some non-insulin injectables that people can kind of move up to. And those are typically given once a week, sometimes once a day, but they're not insulin and they don't have such a risk of low blood sugar. And then beyond that, a physician will usually start a client on a long-acting insulin before they start on mealtime insulin. So I might have someone on Basaglar or Levemir or Lantus. Those are long-acting insulins. They last close to 24 hours, some a little bit less and some a little bit more. The person will usually start injecting once a day around bedtime. And we do want that time to stay consistent. So if you have a client who goes to bed sometimes at 8 p.m. and sometimes at midnight, then bedtime is not the right word to use. We would have to consistently say, okay, what is the earliest time you would ever go to bed? And we're going to inject consistently at that hour. So anyway, they start on the long-acting insulin usually first, and then as needed, the physician will start adding some mealtime insulin, which is a rapid-acting insulin most of the time, something like a Humalog or a Novolog. So a Humalog or Novolog plus Lantus, Levemir, Basaglar, that's very common. For people who have financial difficulties, those insulins are expensive. And so you might still find a person very rarely who's on an NPH, regular NPH. But if there's any way around that, we really try not to go that way, because the long and short acting regimen gives a person a lot more flexibility as to how many carbs can they eat and what time can they eat them. So there's that. There's the standard insulin injections. Then there are pumps. Usually people with type 1 are more likely to get a pump. I don't see people with type 2 on a pump very often unless it is an Omnipod. And I really like Omnipod. It is, you stick it on your upper arm, or you can stick it some other places. It holds about 200 units worth of insulin, and it's got Bluetooth technology. So you can tell your little Omnipod device, hey, I just ate 40 grams of carbohydrate, and it will deliver both your mealtime insulin and your background insulin for you. So Omnipod, I really love for people with type 2. So there's that. And then we are seeing a little bit of people starting on these smart pens. So very similar to the Omnipod, you have to tell your device how many grams of carb you just ate, what's your insulin right now, and all kinds of information like that. There's an algorithm in there, and of course it has to be programmed specific to the individual. But the pen will then deliver the right amount of insulin based on what's my blood sugar right now, how much insulin do I have on board right now, and how many grams of carbohydrate did I just eat. So Medtronic makes one of those, and those are interesting. And then lastly, we have something called continuous glucose monitors. So if you've ever seen a person with diabetes whose fingers just look terribly beat up, sometimes the whole ends of their fingertips are bruised and sore, continuous glucose monitors are the answer to that. Basically, we have a couple different kinds. There's the Freestyle and there's the Dexcom. Freestyle requires that the client check their blood sugar manually. They're not having to draw blood, but they are having to take a device, a receiver, and sort of wave it over the transmitter that's attached to their body in order to check their blood sugar. So it is dependent on that person taking an action. I really like Dexcom the best because a Dexcom will check your blood sugar every 5 minutes, whether you ask it to or not. And you can set alerts on your Dexcom device that say, hey, if my sugar is rapidly falling, or if I get to 75 milligrams per deciliter, or if I get to 180, I want you to alert me. And that's really great for people who are a little bit more erratic. It's also great for people who run low or high in the night, especially for people who live alone. What happens if you're asleep and your sugar bottoms out because you took too much insulin the night before, or you didn't eat as many carbs? Potentially you don't wake up. So I love Dexcom because it will audibly alert and hopefully wake up a person who is experiencing an extreme low or a really high blood sugar in the night.
Yeah, and I guess to sort of wrap up here a little bit, what would you say is a great way for someone to support a family member or a friend who is a newly diagnosed diabetic, whether it's type 1, type 2, and they're going through a lifestyle change? What would you sort of recommend is the best way to help support them on that journey?
They already know what they're supposed to eat, right? So many times people say to me, oh, my spouse drives me crazy. They tell me all the time that I'm not supposed to have this and I'm not supposed to have that. And you know what? I get in the car and I go and I get myself a hot fudge sundae and I eat it when they're not looking. So we don't want to create a situation where a person feels blamed or shamed around their disease. The best thing you could do is ask that person, what do they want? Do you want me to stop keeping sweets in the house? Do you want me to walk with you? Do you just want me to leave you alone and let you handle this all on your own? So let your family member, let your loved one drive that process for you, and never say, should you be eating that? We have a conversation where we talk about food pushers and food police and what to do with those people. So a lot of times I advise clients to just, if someone says something to you like, should you be eating that? Then, you have permission to ignore that person. You don't know whether they're hungry, and they don't know really whether you're hungry. They have no idea what your blood sugar level is. Maybe you need cake to prop it up right this minute. They don't know. And really, it's not their business. Your body is your body. And so if you're a family member of somebody with diabetes, let them handle their own process unless it's an emergent situation.
Yeah, and that's such great advice that we talk about with, honestly, anyone going through lifestyle changes. Is just, it's never helpful to be that person who is, oh, I thought you were eating healthier this week, or, oh, I didn't know you were going to eat cake. And it's never helpful to be that person. So we have talked about that before, and obviously it applies 100% to diabetes as well. So just don't be the food police.
It's never helpful to be that person.
Yeah. Don't be the food police.
Yeah, don't.
Well, thank you so much for coming on. This was so much great information, and hopefully everyone learned something, whether they know someone with diabetes or they don't, or they just wanted to know more. Thank you so much. And again, Julie's book is out. We will link it in the podcast notes if you're interested in reading more about what she has to offer for diabetes. So thank you so much, Julie. It was so great to have you on.
Thank you. I enjoyed being here.